Welcome back to the Public Health Practice Gap. Imagine for a moment a vault. Inside this vault is the sum total of human knowledge on how to keep populations healthy. We have decades of peer-reviewed literature. We have clinical trials with sample sizes in the tens of thousands. We know exactly how to prevent type 2 diabetes. We know precisely how to reduce the burden of cardiovascular disease. We know how workplace stress chemically alters the human body. The evidence is pristine. It is peer-reviewed. It is bulletproof. But then we take that pristine evidence out of the vault. We carry it into a hospital, or a corporate boardroom, or a community clinic. And within months, the program we build around that evidence quietly falls apart. I am your host, Bradley Fevrier, public health educator and founder of Next Gen Public Health Consultancy. Each week on this show, we explore the liminal space between what public health knows works and what actually happens in practice. We examine the structural, operational, and financial barriers that prevent brilliant public health ideas from translating into real-world impact. Because here is the hard truth about our industry. In public health, the problem is almost never a lack of evidence. The problem is the assumption that the evidence implements itself. Last week, we discussed a quiet seismic shift happening across healthcare and the corporate world. We talked about how corporate wellness is evolving. It is shedding its reputation as a fluffy workplace perk and morphing into a critical piece of public health infrastructure. Employers are waking up as population health actors, not because the C-suite suddenly took a deep interest in epidemiological theory, but because they are staring down the barrel of an economic reality. They are facing compounding, unsustainable, rising insurance costs. They are dealing with workplace absenteeism, the rising tide of chronic disease, and widespread mental health strain. When those pressures accumulate on a balance sheet, organizations inevitably arrive at the exact same question public health professionals have been asking for a century. How do we prevent disease before it becomes catastrophic and expensive? It's the right question. But today, we are going to look at the darker side of the coin. We are going to examine something deeper and much more frustrating. We are going to look at why, even when these organizations attempt to implement prevention programs, the vast majority of them fail. And I want to be very clear up front. They do not fail because prevention is a myth. They do not fail because the science is wrong. They fail because the systems responsible for delivering prevention are fundamentally hostile to it. To understand why this happens, we need a framework. I call this Public Health Practice Gap Model. If you subscribe to the Next Gen Public Health Brief and saw the diagram in this week's newsletter, you'll recognize this structure. For those listening, I want you to picture a timeline with 4 distinct stages. This is the journey of public health knowledge. First, we have the evidence stage. This is the domain of academia and research. This is where we conduct clinical trials, gather epidemiological data, and analyze population health trends. In this stage, we isolate variables. we prove beyond a shadow of a doubt that intervention X leads to outcome Y. Second, we have the policy and guidelines stage. This is where evidence gets translated into rules. Public health agencies look at the data and publish guidelines. Hospital systems create clinical protocols. Insurance companies define what they will and will not cover. The science becomes a mandate. Third, we have organizational operations. This is where the rubber meets the road. This is the messy reality of execution. Budgets have to be allocated. Programs must be designed. Departmental responsibilities are assigned. Technology systems like electronic medical records have to be configured to track the new initiatives. And finally, the fourth stage, real-world outcomes. If everything goes perfectly, population health changes. Disease incidence falls. Healthcare costs shifts downwards. Communities thrive. Evidence, policy, operations, and outcome. This is the ideal pathway. It looks clean on a whiteboard. It makes perfect sense logically. But in reality, a massive fault line exists between stages 2 and stage 3, between policy and operations. The fault line is what I call the public health practice gap. The practice gap is the exact moment when a beautiful public health idea enters a complex organization and violently collides with reality. It is the phenomenon where policies say one thing, but operations dictate another. Let me give you a few rapid-fire examples of what this looks like in the wild. A national guideline highly recommends preventative diabetes screening for all high-risk patients, but the clinic's patient flow workflow simply doesn't have the 6 extra minutes required to administer the screening and log it. A major hospital system issues a memo recommending comprehensive smoking cessation counseling, but the clinicians receiving that memo are expected or evaluated and compensated entirely on patient throughput, how many patients they see per day, not on counseling time. A mid-sized employer wanting to do the right thing decides to run a workplace wellness program to combat burnout. But the Human Resource Department, which lacks any formal public health training, is tasked with designing it in their spare time. The result is entirely predictable. The policy is officially on the books. The evidence backing it is flawless, but the implementation completely collapses. Let's ground this. I want to walk through 2 extended real-world scenarios that illustrate exactly how this plays out. Case number 1, the hospital paradox. Imagine a large, prestigious hospital system. The leadership team looks at their community health needs assessment and decides to launch a massive preventive health initiative aimed at reducing cardiovascular disease. They are following the science, and the science is robust. Lifestyle counseling works. Consistent blood pressure monitoring works. Dietary intervention works. So the hospital clinical leadership publishes a beautiful formatted set of guidelines. They send it out to every primary care physician in the network, encouraging them to spend time discussing cardiovascular prevention with the at-risk patients. On paper, this program is a triumph of public health translation. It checks every box. But then, Monday morning arrives, and the operational reality takes over. Dr. Smith, a dedicated primary care physician, walks into her office. She wants to do this preventive counseling, but her operational reality is dictated by the schedule. She has exactly 15 minutes appointment slots. Within those 15 minutes, she has to greet the patient, address the acute issue they came in for, say a persistent cough and a sprained ankle, navigate a clunky electrical medical record system that requires extensive drop-down menu documentation, and formulate a treatment plan. Furthermore, the hospital reimbursement structure is built on RVUs, which is relative value units. The system financially rewards procedures and acute interventions. It does not meaningfully reimburse a 10-minute conversation about sodium intake and stress reduction. Certainly, this brilliant cardiovascular prevention program is not replacing anything on Dr. Smith's plate. It is simply layered on top of an already overflowing plate. It becomes something she is expected to do in addition to everything else, with no additional time, no additional resources, and no financial incentive. The result? The program exists technically. You can find it on the hospital's intranet, but the real-world impact is virtually zero. Prevention didn't fail. The evidence did not fail. The operations simply were never redesigned to support the prevention. Now let's pivot to the corporate sector. A Fortune 500 company realizes its healthcare premiums are skyrocketing. They launch a highly publicized corporate wellness initiative. The intention is genuinely good. Leadership wants a healthier, more vibrant workforce. So they buy a software platform. They implement step count challenges. They integrate fitness apps. They offer a points system where employees can earn a branded water bottle or a small premium discount for tracking the activity. But let's look at the operational context of this workplace. The program focuses 100% on individual behavior, but the environment that shapes the behavior remains completely untouched. Employees are still working 50 to 60 sedentary hours a week. The culture still tacitly rewards people who eat lunch at the desk while answering emails. Break structures are rigid. The cafeteria food options are highly processed. The project deadlines are unrelenting, keeping baseline cortisol and stress levels sky high. We are asking individuals to out-willpower the environment. A few months go by. The initial novelty of the step challenge wears off. Participation plummets. The CFO looks at the software subscription costs, looks at the stagnant healthcare premium, and concludes, well, corporate wellness doesn't work. But the program didn't fail because walking isn't good for you. It failed because it addressed individual behavior while completely ignoring the organizational system driving that behavior. Once again, we fall into the practice gap. The evidence existed. The execution ignored the operational reality. There are three structural pillars why the gap exists. So we have to ask ourselves, why does this happen so consistently across so many different sectors? Through my work consulting with healthcare networks and corporations, I have identified three structural reasons why the practice gap is so persistent. Number one, evidence is produced outside of operations. Most public health research is born in highly controlled environments. It happens in universities, controlled clinical trials, and heavily funded pilot programs. These environments are built to protect the integrity of data. They allow researchers to isolate variables and prove causality. But the second you take that pristine evidence and drop it into a living, breathing organization, 100 new variables instantly appears. Budgets fluctuate. Staff turnovers happen. IT departments say the new software won't integrate with the legacy system. Organizational politics get in the way. Regulatory constraints tie your hands. Academic research rarely, if ever, accounts for the operational friction. It tells us what to do, but it is blind to the environment in which we have to do it. Number two, policy translation is incomplete. The second problem happens during the handoff from evidence to policy. When evidence becomes a mandate, the recommendation usually sounds like this. Healthcare providers should counsel patients on lifestyle changes. It sounds entirely reasonable, but to an operations manager, that sentence is a nightmare. It leaves all the critical questions unanswered. Who specifically performs the counseling? Is it the physician, the nurse, or a health coach? How much time is allocated for this? What billing code is used to ensure the hospital gets paid for that time? Where is this tracked in the software? Without rigorous operational design, a policy isn't a plan. It is simply an aspiration written on official letterhead. Number 3, organizations optimize for efficiency, not prevention. This is the hardest truth to swallow. Our healthcare systems and our corporate structures were built to treat acute problems. They were built for efficiency, not for the long game of prevention. Hospitals optimize for bed utilizations, procedure volumes, billing workflows, and acute care throughput. Corporations optimize for quarterly earnings, immediate productivity, and overhead reduction. Prevention is the antithesis of immediate efficiency. Prevention requires long-time horizons. It requires population-level thinking, not just patient-level thinking. It requires deep cross-departmental collaboration. And perhaps most challenging of all, prevention often produces financial benefits outside the department that paid for the program. The Human Resource Department might pay for the wellness program, but the Operations Department reaps the benefit of lower absenteeism. This fundamental misalignment of timelines and incentives is the concrete pouring into the practice gap, cementing it in place. If you are listening to this, you are likely someone who cares deeply about population health. You might be an epidemiologist, a corporate wellness director, a hospital administrator, or a nursing leader. This brings us to a critical inflection point for our profession. If public health professionals want our work to actually matter, if we want to see the needle move on chronic disease and community well-being, we have to step out of the evidence layer and firmly into the implementation layer. We can no longer just be the people who provide the data. We have to become the architects of the system that deliver the data. That means we have to become fluent in things that aren't traditionally taught in public health schools. We have to understand organizational design. We must learn how to map operational workflows. We need to be able to read a P&L statement and understand budget structures. We must master the psychology of institutional incentives. The future of public health leadership will not be confined to government health departments or an academic research lab. It is going to live directly inside the institutions that shape daily human behavior. Employers, school systems, hospital networks, insurance companies. These environments are the front lines. They are where prevention will either succeed and scale or quietly disappear into the ether. So how do we fix it? How do we build a bridge across public health care practice? There are 3 concrete strategies we must adopt. First, we must operationalize prevention. We have to stop designing ideal programs for ideal worlds. Programs must be reverse engineered around real-world workflows. If a primary care physician only has 15 minutes with a patient, our prevention strategy must seamlessly fit inside those 15 minutes, or we must provide ancillary staff to handle it. If an employer operates entirely on quarterly performance matrices, our wellness initiatives must have milestones that align with those timelines so leadership stays bought in. We cannot ask operations to adapt to that evidence. We must adapt the delivery of the evidence to fit the operations. Secondly, we must align the incentives. This isn't a universal rule of human and organizational behavior. Organizations implement what they are rewarded to implement. If a prevention program saves money for the patient, but reduces short-term revenue for the hospital, that program will constantly fight for survival. Public health leaders must work with finance and policy teams to design systems where doing the right thing for population health also aligns with the institutional bottom line. Value-based care models are a step in this direction, but we need to push harder. Thirdly, we must embed public health expertise deeply into organizations. The most successful prevention strategies I have ever seen occur when public health professionals are sitting directly inside operational teams. We cannot just be outside consultants throwing PDFs over the fence. We need public health thinkers sitting next to the software engineers designing the EMR. We need them sitting next to the HR directors designing employee benefits. We need them embedded, helping to build the systems from the ground up. Why does this matter right now? We are recording this in 2026, and healthcare systems are constantly entering a period of massive structural transition. The math is no longer working. Chronic disease prevalence continues to rise. The cost of healthcare continues to escalate at a rate that is economically destabilizing. Workforce health has transcended being an HR issue. It is now a fundamental operational risk for employers. These massive pressures are forcing institutions to take prevention seriously. They have no other choice. But if we do not actively address the practice gap, millions of dollars and thousands of hours will be poured into prevention programs that will underperform. And the tragedy is, critics will look at these failures and say, see, prevention doesn't work. But we will know the truth. Prevention doesn't fail. Implementation fails. So I want to leave you with this challenge. The next time you are sitting in a meeting or recording a journal article and you see a public health recommendation that seems incredibly obvious, I want you to stop and ask a different question. Don't ask, is the evidence strong? Assume the evidence is strong. Instead, ask, has the system been redesigned to deliver it? Because between human knowledge and human outcomes lies the vast, complex space. That space is where public health either succeeds and changes lives, or where it quietly stalls out. And exploring, understanding, and ultimately conquering that space is exactly what this podcast is about. If today's conversation helped clarify why the initiatives you are working on might be hitting a wall, and how prevention actually functions inside complex organizations, I highly recommend you check out the deeper analysis in my weekly newsletter, the Next Gen Public Health Brief. Each week, we break down the structural forces changing healthcare, prevention, and population health strategies, giving you the tools to become a more efficient leader in this space. You can subscribe right now at nextgenpublichealthconsultancy.com. New episodes of the Public Health Practice Gap are released every Tuesday. Until next time, I am Dr. Bradley Fevrier, and this has been the Public Health Practice Gap.